This recording is going to cover acid-base imbalances. The alkalosis would represent acid-base imbalance that results if the pH is higher than technically 7.45, but we're going to use the average of 7.4. If you're acidotic, it means your pH is less than the 7.4. What we're going to do is we'll talk about certain things that can lead to acidosis and certain things that can lead to alkalosis, and then how our bodies will compensate for it to keep the pH from changing so drastically. Now, and we'll also differentiate between respiratory versus metabolic acidosis or alkalosis. So, respiratory acid-base disorders, the primary dysfunction or abnormality has something to do with gas exchange. What you have a elevated or depressed levels of carbon dioxide in the extracellular fluid. So it has something to do with gas exchange in some way, shape, or form. And the primary thing that's causing the changes in pH is the changes in carbon dioxide levels. And just again to remind you, is CO2, if we have, say, a problem with gas exchange and CO2 levels are accumulating, just remember, carbon dioxide combines with water, that forms carbonic acid, and then that dissociates into hydrogen ions plus bicarbonate. So if I have, say, an accumulation of CO2, because an issue with gas exchange, that's going to lead to what we call respiratory acidosis. If I have depressed levels of CO2 because of an abnormality in respiratory function, I would actually have respiratory alkalosis. Now, with metabolic acid-base disorders, we have either a accumulation or generation of our fixed acids, organic acids, or loss of them. What they do is it affects the bicarbonate levels in the extracellular fluid, or I say anything affects the bicarbonate levels. And I just kind of want to show you the relationship between, say, if I've generated a lot of fixed acids, like a lot of lactic acid, or acetoacetic acid, it will affect the bicarbonate levels because the role of the bicarbonate buffer system. So if I've generated a lot of hydrogen ions because of this accumulation of a fixed acid, is the bicarbonate that acts as a buffer combines with it, forms carbonic acid, and then that forms, or dissociates, I should say, into CO2 and water. And so the levels of this will actually decrease. And so what you look for, or I should say what clinicians will look for, is looking at changes in CO2. If that's the primary cause, it's respiratory. If it's because of somehow something affecting bicarbonate levels, it is metabolic. And typically, if someone, say, goes into the hospital, what they typically will measure is partial pressures of carbon dioxide. They'll measure your pH, and they'll actually also measure bicarbonate levels. So based on what their findings are, they can distinguish between respiratory and metabolic acid-base disorders. And they also, based on what they see, they can also distinguish between, is it just acute episode or has been chronic. And so they can look at what's happened in regards to compensation. Is they've had time to compensate or not. And that's for another discussion. So let's look at some of the acid-base disorders. But first, what they all have to somehow involved is, remember, chemical buffer systems. These work very quickly. They're the first to act. They're going to prevent those drastic changes in pH, but they're a short-term fix. I have to somehow get rid of these. So I need to either do something with my respiration, or get rid of it by the kidneys. Then we have respiratory compensation, which is the second to act. Respiratory compensation, though, will not occur with a respiratory acid-base disorder. That's the function or malfunction to begin with. So if you've got a problem with respiration to begin with, you can't compensate it by changing your respiration. That was the primary cause of the condition. Renal compensation, though, will apply to all acid-based disorders, whether it be metabolic-based or respiratory-based. So renal compensation will always be, or what we see will always be the same for a respiratory or a metabolic acid-based disorder. The chemical buffer systems, they'll be the exception with respiratory acid-based disorders. The bicarbonate buffer system won't be effective. You'll have to use all the rest of them, okay? So that'll be another difference. So let's do some causes of acidosis. So the first one is we're going to look at respiratory acidosis. So somehow we are hypoventilating. So if your ventilation rate is depressed, I'm not going to get rid of CO2. And so CO2 levels will accumulate. And that would lead to being acidotic. So examples, chest trauma. Obviously, if you got trauma to your chest, ventilation may be affected. Certain neuromuscular conditions can affect your ventilation. If you have obstruction of the airways, COPD is chronic obstructive pulmonary disease. That somehow will impair gas exchange. And so you're going to retain carbon dioxide. So somehow you're retaining carbon dioxide. Pulmonary edema, that can impair gas exchange. And certain drugs like barbiturates can suppress ventilation at the level of your brainstem. So these could all lead to having respiratory acidosis. So what do we have to try to compensate for this? Is we can use buffer systems other than the carbonic acid bicarbonate buffer system. And there is no respiratory compensation because that's the problem to begin with. But we will have renal compensation. So with this, we would have, we'll just kind of do general first, is you would have increased excretion of hydrogen ions in your urine. So this would be, you'd have a slightly more acidic urine, because that's what we need. We want to get rid of hydrogen ions. You would produce more bicarbonate, and that production of bicarbonate is a result of the urinary buffer system, and that would be the ammonia buffer system. Use of that helps to create new bicarbonate. You're going to need that, a little bit more of that around. You will metabolize glutamine in the kidneys, I should say kidneys, which is important in this ammonia buffer system. So that's how we're going to compensate for it. Okay, now what about metabolic acidosis? So with metabolic acidosis could be caused because of a accumulation of fixed acids. It could be a loss of bicarbonate from the body. So, for example, a loss of bicarbonate from the body can be from severe diarrhea. because the contents of your intestine, there's a lot of bicarb in there to help to neutralize and protect the mucosal lining of the intestine. So if you have a lot of diarrhea, you can lose bicarbonate. That could lead to acidosis. A diabetic ketoacidosis, diabetics, if they're managing their insulin levels well, they're not taking their insulin, not managing, I should say, their glucose properly, is they start producing a lot more ketone bodies because they're going to rely heavily on protein, not protein, fat for energy. And so you can get ketoacidosis. And so those ketone bodies are acids, so that can happen. An overdose of aspirin, that's what salicylate OD is. So there's a number of different, oh, actually another one I want to add that's not on here is lactic acidosis. Can do it, like real severe exercise, and there's also some metabolic disorders that are associated with more production of lactic acid. Those are things that can cause metabolic acidosis. Kidney failure also is something that can lead to metabolic acidosis. And so what are ways to compensate for it? Well, we'll use your buffer systems, including the carbonic acid bicarbonate buffer system. That will help to protect the extracellular fluid very quickly. You have respiratory compensation, and so you will have an increased ventilation rate, which helps to rid the CO2, because if I do, let's just say what's going to happen is bicarbonate combines with hydrogen ions. That forms carbonic acid that dissociates in CO2 and water. And if we increase our ventilation rate, we're going to get rid of that carbon dioxide there. Now, that increase in ventilation rate is going to be what will cause that ventilation rate is actually going to be mediated primarily through the carotid bodies. They monitor the hydrogen ions in your extracellular fluid, and that will trigger the medulla oblongata to increase your ventilation rate. Now, renal compensation, you'll have, it's the same type of compensation as you saw with a respiratory acidosis. So I'm just going to go back here because I don't want to write the same thing over again, is you have increased excretion of hydrogen ions, so you're going to have a more acidic urine. You're going to produce more bicarb. Okay, you're going to, and I should also add that you're going to try to reabsorb as much bicarb as you possibly can. So you might be filtering bicarb in the kidneys. You don't want to lose it in the urine. So you're going to absorb. So I'm going to add that to this one, reabsorb, because it'll apply there. So you reabsorb as much bicarb as you possibly can. That's any that's been filtered. So you increase reabsorption of bicarbonate. Try to produce some more if you can using that ammonia buffer system. And that buffer system is, again, a very good urinary buffer system. So allow us to get rid of a lot more hydrogen ions. And that system is dependent upon the metabolism of glutamine in the kidneys. So the renal compensation is the same for respiratory as well as metabolic acidosis. Okay. Now let's move to alkalosis. So respiratory alkalosis. So you notice things that say cause hyperventilation. You have an anxiety attack. You start to increase your breathing. You're blowing off a lot more CO2. So if you're blowing off a lot more CO2, your pH is going to start to increase. A hyperventilation can also happen at higher altitudes. When the partial pressure of oxygen gets too low at the higher altitudes, that is a potent stimulus for you to increase your ventilation at the higher altitudes. Pregnancy, some women tend to start hyperventilating. It's like during childbirth. And I had a colleague that he would explain to his students that his wife with delivery of one of their daughters is she started hyperventilating. And as a result of the hyperventilation, she was causing an acid-base disorder, and her fingers started to get tingly because it was affecting the nerve function. And you know what they did for her? They gave her a paper bag, and she breathed in the paper bag, so she was rebreathing her carbon dioxide to try to get her pH back to where it's supposed to. Other conditions can result in hyperventilation, but these are like the main ones. This is not as common as any of the other ones. So what can we do to compensate? Well, the buffer systems will be employed except for the carbonic acid bicarbonate buffer system, because it's a respiratory acid-base disorder, and we will have renal compensation. So the kidneys can compensate for respiratory alkalosis. And so in this case, you would excrete an alkaline urine. And so how are you going to excrete an alkaline urine? So you're going to decrease your reabsorption of bicarbonate. You will increase, let's put it that way, decrease the reabsorption of bicarb, and so you end up having more bicarb being released into your urine. Your metabolism of glutamine is going to be decreased because I don't need to bind up any hydrogen ions. I don't need to produce any more bicarb. So decrease metabolism, I can't say it, of glutamine. So that ammonium buffer system is not going to be employed in this one. Those are the main things that's going to happen. Just think logically. I'm going to get rid of more of bicarb for this one, for you to compensate. Now with metabolic alkalosis, so loss of gastric juices. Now here, this obviously is something someone's directly gone up and put a tube up into this guy's, through his nose into his mouth and pumped out some gastric juices. But you can do vomiting. So vomiting where you're losing a lot of your stomach acid. So here we're losing acid, or you've gained base. So a loss of gastric juices, so that's vomiting. So a lot of people overuse antacids, so they have a lot of base in it. Certain medications can cause metabolic alkalosis. So what would be the compensation for it? Well, all your buffer systems, including the carbonic acid bicarbonate buffer system. So with this one, we're alkalotic. I need to somehow get some hydrogen ions in solution. And so with this, this is the direction that we're going into. Oops. So why are we going in this direction? So what's going to happen is we're going to have respiratory compensation. We're going to decrease ventilation so we can retain more carbon dioxide. Renal compensation will also take in effect. And with this one, again, it's going to be the same as we have here. We're going to excrete a more alkaline urine because we're going to decrease our reabsorption of bicarb, not going to metabolize that glutamine, so we can try to get that pH back to where it's supposed to be. So that's what we're going to do for that one. Okay. Now I just want to briefly mention what I have talked about previously. Is there's diagnostic tests to try to determine if a patient has acidosis or alkalosis. Typically, it can obviously measure the pH, but I can measure the pH, and that pH can actually be between 7.35 and 7.45, but they have an acid-base condition. How the heck can that happen? Well, it's because they've compensated. If you have full compensation, that pH can be in the normal range, but how are you going to know there's something up? Is these values are going to be off. Okay? And obviously they're struggling, and so, but you can have, and that's only going to last for a certain amount of time. At some point, you can't, that compensation not going to last forever. So you can have a normal blood pH with an acid-base disorder because of full compensation. Now, looking at the levels of CO2 and bicarb, looking at pH, you can distinguish between respiratory and metabolic acidosis or alkalosis. So let's just look at this here, just for fun. We'll start with it's perfectly, we're just going to look at the pH first. So check the pH. pH is off. So if someone's less than 7.35, okay, they've got acidosis. Well, is it respiratory or is it metabolic? Easily measure the partial pressure of carbon dioxide in their blood. If it's increased, they've got respiratory acidosis. Because I had mentioned if the primary cause of respiratory acid-base disorders is primary changes in carbon dioxide levels. So if you have an elevated levels of CO2 and the pH is less, they've got respiratory acidosis. If the levels of CO2 are not increased, and then it's metabolic acidosis. But then if you look at the CO2, if its CO2 is normal, this is something that came on relatively suddenly, it's acute, they haven't had time to compensate for it. Do not worry about this anion gap. That is, even I can't even explain it. I'm not qualified to explain it, so I'm not going to cover anion gap. But I'm just going to stop at this point here. If the person, the CO2 was not elevated, and their pH is low, but actually their CO2 was low, this has been compensated. They're starting to compensate. They have chronic metabolic acid-base acidosis, because the compensation for metabolic acidosis is to increase their ventilation to help get rid of that carbon dioxide. And so this is where you can distinguish between is it compensated or not for the metabolic acidosis. Now if we go back to the respiratory acidosis, we've already figured out, okay, it's respiratory acidosis. Is it acute or is it chronic? Now they're going to look at the bicarb levels. If it's increased, they have had time to compensate. It's chronic. So why would the bicarbonate be elevated? So with respiratory acidosis, they have primarily renal compensation. And so what they're going to try to do is they're going to produce more bicarb because of that metabolism of glutamine. And so that increased bicarb is an attempt to try to keep the pH from dropping too much. If the bicarbonate levels are normal, then they haven't had time to compensate. Okay, so that's a way to distinguish between compensation or non-compensated acidosis. And if we go over here, for the alkalosis, okay, their pH is higher. It's greater than 7.45. They're alkalotic. First thing let's check is the CO2. CO2, if it's decreased, we know it's respiratory. That's the primary defect. If I see really low levels of CO2, I would expect that the pH would be elevated. If it's not respiratory. So if it's decreased, you don't have to memorize these values, they then check bicarbonate. If the bicarbonate is decreased, then they know it's a chronic condition they've been trying to compensate. If it's not, or just very slightly decreased, they haven't had time to compensate for it yet. So why would bicarbonate levels be decreased in someone with respiratory alkalosis? Alkalosis is because of the renal compensation. So with the renal compensation, what you're expecting is they're going to try to excrete a lot of bicarbonate, get rid of excess bicarb. And so the levels of bicarb in their body would be less. Now, if we look at metabolic alkalosis and we check carbon dioxide, or sorry, you check carbon dioxide and you see it says it's increased, it's not decreased. Now, if it's increased, you're like, if CO2 levels increase, I would accept someone's pH should be low. Well, why would it be increased with someone with metabolic alkalosis? Well, remember what the compensation for metabolic alkalosis is. One of them is going to be changes in respiration. And so they're going to have depressed breathing, and they're going to retain more CO2 to try to keep that pH from dropping drastically. And so this is what they're doing, is they're kind of just playing detective and trying, by looking at CO2 levels and bicarbonate levels, they can distinguish between a respiratory or a metabolic condition, and then also see if it's acute or it's been compensated, or it's chronic, I should say.